Uh, Please mute yourself, ma'am. Otherwise, echo sound will come. We are live now. Dr. Urvashi, you're here? Yes,
Yes, doctor, I'm here.
you can start.
Okay. Welcome back, everyone, on this lovely Sunday morning to watch yet another session of our Dental Reach series, Right Bite Harmony Between Aesthetics and Function. Dental Reach is a professional site and forum for dentists. It's a place to be visible as a dental practitioner and get appreciated by fellow professionals. Thousands of dentists use Dental Reach to find reliable information on dental education, just like you all are here to up your dental game today. I am Dr. Urvashi and I'll be your host and host for the session while we venture into the second part of smile rehabilitation strategies with none other than Dr. Deepa Ravichandran. Today is going to be an interesting session where we compare and contrast two completely opposite cases of smile rehabs designed to give you confidence in identifying and managing high ticket cases in your practice. To describe our speaker for the session briefly, Dr. Deepa Ravichandran is a prosthodontist in Navi Mumbai, where she runs a successful private practice under the helm of Dental Park. She has won awards at both state and national level in her master's program for both paper as well as poster presentations. She has many publications in index journals, Guidant, Famdent, to name a few. Presently, she is the brand ambassador and moderator of Dental Reach, the recipient of Goma Award for 2021 and 2022, recipient of Doctor's Choice Awards, National and City Winner 2021, the mentor for Pulp and Activa Pronto Challenge, silver winner in the Dental Divas Endo Resto Contest 2021. Contributing author in How to Conquer Dental School, a one of a kind novel giving young undergraduates a unique perspective in navigating the maze that is dental school. Her forte lies in full mouth rehabilitations, smile designing, and restoring cases of complex occlusion conservatively. She has received acknowledgement for the same from peers and patients alike. Over to you, Dr. Deepa, ma'am.
Thank you so much for the wonderful introduction, Dr. Urvashi. And without much ado, let us just start with our presentation for today. So just give me a minute. I'm just going to share my PPT. Is it visible?
Yes, doctor, it's visible. If you could just go back to the first slide.
Yes, I'm not able to do that. It's not giving. Just hold on. Just give me a minute. Yes, I'm getting there. Just 1 minute.
Yeah. Slides are moving. We can see.
Yeah. So it's a case-based learning series. So what makes or breaks the smile curve? Now, that's a really very, very important question. And we're going to realize just how important it is and find the answer to that question in our journey of a clinical webinar for today. So today's webinar is going to be a little different because rather than go down the traditional route of just presenting a case, which is what I had done for the last webinar in the Smile Rehab case series, today I'm going to be doing a compare and a contrast. So what do I mean by this? What I mean is sometimes in smile rehabs, we have cases at two extreme ends of the spectrum, and it's very difficult to identify which is which. So in the last webinar, I had done a case which belonged to one end of the spectrum. And in today's webinar, I'm going to be doing another case which belongs to the other end of the spectrum. So it gets a little more interesting when we begin to compare and contrast both these two different cases because they're similar in some respects, but yet they are very, very different when it comes to the way we handle them. And on that note, what do I mean by a smile rehab? Why am I not calling it a smile design? So although I'd explained this last time, I'll just go over it in brief. A smile design is relatively simpler. It's something where we can change the aesthetics given, but we do not change the functional occlusion. In that sense, we do not change the overjet, the overbite, or the anterior guidance. But what we can provide the patient is simple and subtle differences in the smile curve, which could be closure of a diastema or just changing the angulation and the rotation of the teeth with veneers or with composite laminates. But if we have to change the anterior guidance of the patient or we have to change the overjet or the overbite or create an anterior guidance where none exists, then such cases are called smile rehabs. Okay, so last webinar we explored a smile rehab where I had to increase the anterior guidance, and this time we're going to explore a case of a smile rehab where there was no anterior guidance to begin with. So this is the pre-op of the patient, and as you can see, there is absolutely no curve of Spee. There is severe proclination of the upper anteriors. There is rotation of the lower anteriors. And there is also a complete lack of overjet and overbite. It's almost approaching an open bite, but not quite. And at the same time, it is an anterior edge-to-edge bite over here. So when we have a case like this, which is completely lacking any type of overjet and overbite, that case completely lacks anterior guidance. And we now need to create anterior guidance where none exists. And what exactly is anterior guidance? I will be explaining that in detail in the forthcoming slides, so just bear with me. I would just like you to analyze this picture and just think of the gamut of corrections that this particular patient is going to need, which also includes the hypertrophic gingiva. So why was this case the way it is? There's a little history here that we need to go into. So she was a very young lady, around 21, when she entered my operatory, and she actually had braces on her teeth. And the first thing she said was, Doc, I do not want these braces. My teeth hurt. They hurt all the time. They hurt every time I speak, every time I eat, every time I drink, every time I basically move my lips. And it has gotten to a point where I'm so ashamed of my smile that I actually cover my mouth with my hand when I smile. So we are talking about a young lady who was also psychologically traumatized. That is one part of it, yes. But when a patient says that she was having very severe pain all through the day, no matter what she did, especially when she was eating and speaking, there are a lot of alarm bells which should go off in her head, because this isn't exactly normal. And you can see that the upper has no curve of Spee while the lower is completely rotated, the arch form. And to add to it, she has a little bit of hormonal history here. She has a pre-existing hormonal condition. So that explains all this hypertrophy that you see in the maxillary arch. Also, the orthodontic treatment in such cases can cause a fair bit of hypertrophy by itself. So we had a lot going on with this patient, but the question that we needed to ask ourselves is, how much are we going to do? And how much do we think is needed versus how much do we actually do, because that's a very important question that we need to ask ourselves in private practice. So I'm going to begin my first compare and contrast over here. So the first picture over here is of today's case. And for those who attended my webinar last time, you would remember this picture. This is of the pre-op occlusion of the previous case. Now you can see that there is a lot of difference between the two cases over here. At least in the second picture, you can see that there is some semblance of an arch form over here. Whereas in this image, there is absolutely no arch form. And there is a lot of issue with the lowers, whereas here, there does not seem to be much issue with any of the lowers. And the patient just seems to require a diastema closure and a proclination mismatch between the centrals and the laterals over here. So all in all, I'm going to have a poll now as to which of these two cases are tougher or easier to deal with. So Dr. Urvashi, could we have a first poll? Our first poll question.
Yes, I've already put up the first poll.
Yeah, so please just click the first thing that comes to your mind. We are all here to learn. So, it's okay. It's okay to make a mistake. So this is a case where there is no anterior guidance and we need to correct it, and we need to create one where none exists. And this is a case where the patient has a low or a shallow anterior guidance, which we need to increase and convert to a steep anterior guidance when we correct this proclination mismatch. So which do you think is tougher to treat between these two? So do we have the answers to the poll? Not yet?
Yes, yes, I'll be publishing the results, but everybody has gone for option B as 100%.
No, what is option B?
Option B is converting a case to shallow anterior guidance is easier for them.
Okay. So I'm really glad that we got this answer, because this opens up a lot of interesting questions and we have a lot of interesting discussion that can take place. And for the record, I would like to mention, if you have any doubts, kindly post it in the chat box, and Dr. Urvashi will just interrupt me and ask me the question, because it's easier to answer the question when I'm at that particular slide rather than to move ahead at the end of the presentation and then try and answer a question when the PPT is no longer in front of me, because these are complex cases that we are discussing. Okay, so that was a very interesting answer. And it's actually the other way. No, what, Dr. Urvashi, could you repeat that answer again? Converting a case to a shallow anterior guidance is easier.
So which is easier, converting a case to a steep anterior guidance or converting a case to a shallow anterior guidance? So everybody responded for the option B, which is converting a case to shallow is easier.
Okay, so y'all are going to understand just how difficult converting a case from no anterior guidance to shallow anterior guidance can be, and why, in the following slides. Okay, now this is something we all need to answer in our practice before we even touch the patient. What does the patient want? Because this is a very, very important question. If we want to convert a high-ticket patient in our practice, it's not so simple, and we all know that. So what are the tools that we need to convert a patient in a high-ticket patient in our practice? See, let's face it. High-ticket patients in our practice are those which require a lot of restorative work. The restorative work could be composites, they could be laminates, they could be crowns, they could be a combination of all of this. They could be an FMR. They could even be a combination of, say, a posterior RPD and anterior crowns and so on. So it's basically a lot of resto. So one of the tools to convert high-ticket restorative cases in our practice, and as I said, they are high-ticket for a reason, because even with all these permutations and combinations, the incentive that these patients provide to us in our practice is quite high. And one of the first tools that I employ in my practice is documentation. So whenever I have a patient with any type of complex work, which they require, combinations of all that I've mentioned earlier, I show them similar cases that I've done before, which I've already documented. And it helps a lot, especially when I tell the patient that, these cases are available on my Facebook page for my clinic, or they're available on my Insta page, and you can go through them anytime you want, and you can show them to anybody that you want. It makes a lot of difference where the patient is concerned, because it shows more transparency between us, the clinician, and the patient. And it shows that we are not just trying to confuse them in our clinic with showing them something which is razzmatazz, and it's not going to be available for them once they walk out. So that's one very important tool. The other very important tool is understanding the case. One should have a very, very, very thorough understanding of what the patient wants versus what exactly is needed to be done in that particular case, or what we need to do in that particular case, which is often the ideal treatment plan, versus how much of the ideal treatment plan the patient is willing to accept, and which gives us the modified treatment plan. So we need to have this hierarchy in our practice, and we need to be very, very clear in this hierarchy. What does the patient want? What is our ideal treatment plan? And the two coincide together in a Venn diagram, and we get the modified treatment plan. So this is another thing that I had mentioned in my webinar last time also. It's not that crowns are always radical and laminates or veneers are always conservative. It's not that way. Sometimes you need to take into account all the treatment that a patient requires, okay, to get their functional occlusion correct. Because these are smile rehab cases, they are not smile design cases. So in effect, there is something seriously wrong with their functional occlusion, which we need to correct. So we need to make a list of the bare minimum that is needed to correct that functional occlusion. And if you can achieve the maximum of that list with, say, just 2-3 crowns or just a couple of crowns, then it's not really radical. It's actually pretty conservative because you're not touching the posteriors, you're not doing anything else. So the term radical and conservative has to be applied on a case-to-case basis for that particular patient. It's not a broad term that can just be bandied about, and we cannot just come to the conclusion and say that minimally invasive dentistry is always and will be veneers and crowns will always be radical. So now, what did the patient want? Now, when we have a case like this, either a patient can go for ortho or the patient can go for a prosthetic restoration. So this is a case of ortho failure. Okay. Why do I say it's a case of ortho failure? Her teeth are completely rotated. She had been undergoing ortho treatment for 3 years. And instead of correcting a proclination mismatch or whatever she had pre-op, there is now a complete lack of anterior guidance. There is a complete lack of curve of speech. It's converted into an anterior edge-to-edge combined with a lack of anterior guidance, combined with almost a biomax where her anteriors are completely proclined. And to top it all, she says she's got severe pain. So when a patient says that they've got such severe pain and you see such hypertrophic gingiva, it means it's now become a case of trauma from occlusion. So when it becomes a TFO case, ortho just goes out of the window anymore because such cases are accompanied by severe bone loss. So in fact, you have to hasten and remove the braces as soon as possible, because if you don't, the teeth sometimes turn completely mobile. And there are cases where the ortho has failed and the patients have come back to the practice with mobile teeth, and you have no choice but to extract. And I really did not want to go down that road because she is a very, very young patient. So for this particular patient, ortho was completely out of the question. So that left only prosthetic rehabilitation for this patient. So I have radiographs here, and they show you the picture, the exact amount of bone loss that we are looking at over here. So you can see that these are the radiographs of the lower anteriors, these are the radiographs of the upper anteriors. You can see this severe amount of bone loss that has taken place over here, almost 2/3, and in some extent, the bone loss is almost till the apex, like what you can see over here. Okay, and they're not non-vital. They were completely non-vital. So it was a no-brainer that we needed to initiate endodontic treatment. And if they're any which way is non-vital and we are anyway initiating endodontic treatment, it would obviously make more sense to do a prosthetic rehabilitation for the patient rather than any orthodontic rehabilitation. And as I said, that was out of the question because of the severe bone loss that we are seeing over here. Now, the only saving grace in all of this was, thank our stars, the patient did not have any mobility. None of these anterior teeth were mobile. So, sometimes the human body really surprises you. We get patients who have a 1/2 crown root ratio and yet their teeth are mobile. And here we are having a case where there are certain teeth where there is almost no interdental bone present, and yet the teeth were not mobile. So I initiated endodontic treatment, and I went in for a mock-up for this case because I had to retract all the anteriors, right? I have to push them in, so to speak. So whenever you are pushing anterior teeth in or when you are retruding them, your anterior guidance in effect becomes shallow. And when you're pushing anterior teeth out and you're protruding them, your anterior guidance in effect becomes more steep, okay? And I think a few of you who had attended the webinar last time probably felt that, oh God, that's really difficult. But difficult takes on a whole new meaning when it comes to this case. So this was the mock-up. Now, why did I not go in for a digital mock-up? Because I do most of my cases CAD-CAM. In fact, I do all my cases CAD-CAM. So I don't do the non-CAD-CAM cases anymore in my practice. But the reason I did it for this particular case was because when we push or retrude the anteriors, and I'm going to reduce the anterior guidance, and I have to create one where none exists. I wanted to hand articulate the cast, and I wanted to sort of glide the lower cast over the upper in the simulation of the protrusive movement to check how much of a functional overjet and overbite I could give the patient in such a case. Now, the next question could be why? Because I did not do that in my last webinar. There was even a question asked by one of the participants as to whether I had taken a protrusive bite and whether I'd done a phase transfer, mounted it on a semi-adjustable articulator. And back then my answer was no. With experience, you know what angle of anterior guidance you need to give the patient. And I just inputted that value in the CAD itself. So why couldn't I just do it this time? The reason is phonetics. Phonetics play a very, very important role where anterior teeth are concerned. As we all know, our anterior teeth are meant for two roles that they play. One is aesthetics, and that's given a lot of importance. But there is another one which is sometimes not given as much importance as the first, and that is phonetics, specifically the F and the V sounds. So the anterior-posterior positioning of the upper anteriors, that is the labiolingual positioning, as well as the cervico-incisal length of the anteriors, plays a very, very big role in how the enunciation of the F and the V sounds take place. As in, fan has to sound like fan and van has to sound like van. If there is an issue with the anterior-posterior positioning of the upper anteriors, the fan and the van are not so clear. The fan begins to sound like van and van begins to sound like fan. And once the crowns are already milled in the CAD, there isn't much that I can do about it. So since the phonetics was also something that I had to take in account over here, it was not just the functional occlusion alone, we had this added extra part. I wanted to hand articulate the cast in this case, and we are going to see how difficult it actually gets as we go ahead. Okay, so now I'm going to, in brief, explain what is the difference between a shallow anterior guidance and a steep anterior guidance. Okay, so imagine you're in a car and you're driving and you come across two speed breakers. You have the yellow one and you have the black one. Now, as you can see, the yellow speed breaker is far bigger and far steeper as compared to the black speed breaker. So if I would have to brake so that I don't get jolted when I go over the yellow speed breaker, the amount of effort that I would require to deaccelerate my vehicle and to brake would be far greater for the yellow as compared to the black. It's pretty much the same in our mouth. So we have picture A and we've got picture B. You can see the difference in the angulation between both the images. So image A represents the yellow speed breaker and image B represents the black speed breaker. In effect, you have image A, which is almost an obtuse angle, and you have image B, which is an acute angle. So when you have an obtuse angle, what happens is that it is more difficult for the patient to bring the upper and the lower anterior teeth in an edge-to-edge position. It hurts their neck. It literally hurts their neck and their jaw muscles. So they don't do it. They do not incise. Such patients do not incise. Okay. So the angulation which is formed between the palatal surface of the upper anteriors and the incisal edge of the lower anteriors is what is referred to as the anterior guidance. So when it is steep, the amount of effort that is needed for this incisal edge here to travel this, overcome this concavity, travel this distance and reach here is a lot and is often painful. And therefore, patients don't do it. And therefore, a prosthesis or a restorations last in the patient's mouth. But when you have a case like this, where the concavity is relatively less, okay, what happens is the amount of effort that is needed for the patient to move the lower anteriors over the concavity over here and bring it in an edge-to-edge position over here isn't much. So such patients are able to incise with relative ease. And this is the reason why restorations do not last in the mouth of such patients, whether it is composite or whether it is a crown. Okay. And this gets really difficult over here. And this is a very, very, very important concept because the success and the failure of our treatment in the practice hinges and rests on the understanding of this one very, very simple principle. Now, all of this said and done, then why would I, in my right mind, give the patient a shallow anterior guidance when I know fully well that it is very difficult to get the restoration to last in the patient's mouth? Why would I not just give the patient a steeper anterior guidance? Because it's better. It's going to last and it's less headache for us. The answer here is the phonetics. It is the phonetics. So sometimes when you attempt to give a steep anterior guidance for a patient, there is a mismatch in the phonetics. There is an issue with the phonetics of that particular patient. She is not able to speak properly. There is an issue with the fan. There is an issue with the van. So in effect, you are forced to convert the case from a steep anterior guidance to a shallow anterior guidance. Or even if, say you are having a case like the present case where there is no anterior guidance and you have to create one, you attempt to create a steep anterior guidance and it doesn't work out. And so you need to go back to a shallow anterior guidance because, the phonetics are equally important, because aesthetics without function has got no value. And one of the functions of anterior teeth, apart from functional occlusion, which is the position of maximum intercuspation, you also have the function of phonetics. So you need to make a little bit of compromise in the aesthetics sometimes for the sake of function. We cannot have it all sometimes. So it's very important to understand where you make that compromise and how much you make that compromise, because too much of anything is not good either. So now the teeth are very over-prepped. Now, when you see this image, the first thing you understand is that the teeth are completely over-prepped. So there is obviously going to be a retention issue over here, especially when it comes to the lower anterior. So I had to prep them that much because I was doing my best to retrude teeth that was severely over-proclined. So when I'm trying to push them in to that extent, I need to reduce a lot from the labial surface. So I did not reduce much from the palatal here or much from the lingual here, but I did do a lot of reduction on the labial surface. And this is very evidenced by the gutta percha that you can see over here. Now, we all know that gutta percha does not bond. Okay, so why did I not remove the gutta percha and seal it with composite? Now, I basically used the GP over here as a marker for me when I was doing the crown prep, because there are two ways to do crown preps in such cases. One would be to do it in the APT method, where you have a Mockup or a wax up and you make an index out of that, and then you use pro temp and put it in the patient's mouth, and then you basically reduce that the temp that you have given the patient. But I prefer to do it freehand. So all of my preps in all of my cases are freehand. So when I'm doing it freehand, I use the GP as a marker on the labial surface to give me an indication as to how much I have reduced. Because if I can see the GP, it means I have reduced almost everything on the labial surface. I have reduced all the enamel and all the dentine, and now there's nothing left. And any thickness that is now left is due to the lingual and the palatal surface. Of course, before I bonded the crowns, all of this GP was removed and the orifices were sealed with composite. Now, it was here that the case started to get more difficult if possible and more interesting, because she turned out to be a hidden bruxer and clencher. Patients really surprise you in more ways than one. How did I know this? And why do I say she was a hidden bruxer and clencher? Because even after the root canal treatment was done, she still had pain. She had the same type of severe pain that she had when she first came to me with her braces still on. And that didn't make any sense to me, because I was very sure of the endo that had been done. I was very sure that we hadn't missed anything. I was very sure of everything. So it just didn't make sense. There was this niggling doubt in my mind that there was something I was missing, and it had nothing to do with the endo. And a little bit of digging sometimes helps, when you start talking to the patient and you start asking the patient, okay, when you had all that pain in the past, what did you do? Did you take painkillers? How did you deal with it? And sometimes patients do not take painkillers to deal with the pain, but what they do is they end up clenching their teeth. They end up developing a habit of clenching their anterior teeth. And somehow that helps them. It helps to dissipate the pain that they were facing. And that's what this girl had done too. She had gotten into the vicious cycle of clenching her upper and her lower anteriors, thereby becoming a bruxer. And that helped to relieve her of the pain, albeit temporarily. But then the bruxing started its own issues, which would also explain the TFO and the extreme and the severe bone loss that we had seen in the radiographs earlier. So once I realized that she was a bruxer and a clencher, the first thing I did was, after the crown preps, were to give her temps and give her a lower soft split. And the pain vanished almost immediately, overnight. So the deprogramming is very important in such patients. And my next webinar is on deprogramming because I have a different way of deprogramming patients in my practice. I do not give the patient an extra appliance. The reason for that I would be discussing in detail in the next webinar. I prefer to use what I already have as part of the case, mostly. Okay, so in this particular case, what I did, in most cases actually, when I give the patient a set of temporaries for the upper and the lower anteriors, that itself acts as a deprogrammer. But for this particular case, it did not. Why? Why did it not act as a deprogrammer? It didn't. It wasn't enough. The reason is because I was converting her into a shallow anterior guidance, and her overjet and overbite was not enough, and her anterior guidance was not steep enough to deprogram her. In other words, so because her anterior guidance was more shallow, the temps alone were not enough to act as deprogrammers, and I had to give her a lower soft splint. Are there any questions, Dr. Urvashi? If they are, please just do interrupt me in between.
Yeah, actually, there is one question for you.
Yeah.
It is related to the same case, and you mentioned about the patient being a bruxer or a clencher, which you found out mid-treatment.
Yeah, the
So
last
the
time.
question is, yes. So the question is that, is there a difference between clenching and bruxing, which is more damaging? And what are some intraoral clinical signs and symptoms of a clencher to differentiate from a bruxer?
Yeah. So it's a very, very good question, actually. It's a very good question. And then that's one of the reasons, if you see, I have written hidden clencher / bruxer. Okay. Because it's very difficult in such cases to actually be able to pinpoint and identify and say, okay, you are a bruxer, but you are not a clencher. Or, okay, you are a clencher, but you're not a bruxer. We're not really sure. We aren't very sure in such cases. I'm not saying it's in all cases, but we aren't very sure in this case. But I would, but if I had to pick one out of the two, okay, I would say that she was more of a clencher rather than a bruxer, which is why I have put the hidden clencher over here. But at the same time, I could not completely rule out bruxing. And the reason for that was because of the radiographs and the very severe bone loss that I had seen, and the fact that she was a trauma from occlusion case. But the treatment plan remains the same. You need to deprogram them. Now, coming to which is more damaging and how do you identify? Both can be equally damaging. Both can be equally damaging. It's not that clenching is less damaging or bruxing is more damaging. It really depends on the case. Now, what happens with bruxism is a pathologic functional movement. Now, why do we call it pathologic? See, we have something called as an envelope of motion. Now, what do I mean by envelope of motion? It is an area within which our upper and lower teeth move in eccentric motions when we masticate. So in short, they move from the zero position of maximum intercuspation to protrusion, and then they come back to the position of maximum intercuspation, and then they move to left lateral excursion. They come back to the position of maximum intercuspation and go to right lateral excursions. And then they come back to the position of maximum intercuspation. So you have, a figure which you can trace, which looks teardrop shaped in the sagittal plane. And this is known as Possel's envelope of motion. And all of our chewing movements take place within this envelope of motion. Now, as long as these movements take place only during mastication, it's not pathologic. It's not pathologic. That's called functional occlusion. But when a patient starts performing these movements outside of mastication all day long, possibly all night long, that's when it's called bruxism. And that's when it becomes pathologic. So that becomes an unnecessary grinding of the teeth, an unnecessary wear and tear of the teeth. And hence they come back in our practice with the VD lost, with a lot of attrition and abrasion facets on all their teeth, anteriors as well as posteriors. And you know that the bite has completely collapsed. So that is bruxism. Now, I did not find any evidence of wear and tear on any of this patient's posterior teeth. The posteriors were intact. All the problem was only in the anterior. So that's why I would say that she was more of a clincher. But then the radiographs did give me a very different picture with a trauma from occlusion. Now, a clencher is one who simply clenches. Now, what do I mean by clench? Is when we clench our jaw. If we were to clench, like when people get angry, when they clench, they literally bring their anterior teeth in an edge-to-edge position and sort of grind them together. And sometimes there's no grinding involved. They just hold them in that position and clench the masticatory muscles, and that's bad too. Even though there isn't a pathologic movement, the overstimulation of the masticatory muscles basically leads to them being in a state of contraction all the time without relapsing into the state of relaxation. So imagine the amount of lactic acid that is secreted all day long, and the anterior teeth are in that constant edge-to-edge position, whereas that is not something that they can maintain for a very long period of time, like maybe just a few seconds in normal functional occlusion, but not something that one can maintain for several minutes or even hours. So bruxers are those who deal with a lot of stress. And if you ask them, they do say that their lives are stressful or their jobs are stressful or for whatever may be the reason. But clenchers are those who develop the habit as a means of circumventing some sort of unexplained intraoral pain that they're experiencing, which is what happened in this case, because it gives them momentary relief, So that is, as I said, the difference is very subtle, and sometimes it's very difficult to make out which one the patient is. But if you don't have bare facets on the posterior teeth, most probably the patient is a clencher rather than a bruxer. Are there any other questions, Dr. Urvashi?
No, this was the only one. I will ask if there are any.
Okay.
And I'll stop you when I.
Okay, so we come back. So we come back to our present slide. So now I'm going to go back to another compare and contrast over here between the case at present and the case that we discussed in the last webinar. So you can see that, oh my God, there is a whole world of difference. I don't have any curve of SPI over here, and at least I have some curve of SPI over here, right? We can see something over here. I can even trace a line with my mouse over here, if you can see this. Yes, I do need to bring these two central incisors in the same plane or in the same arch form, so that I can generate a curve of SPI. But otherwise, there is a curve of SPI which exists till here and which exists from here to here. I just need to bring these two centrals to coincide, and probably we get something like this. But when you see the first image over here, it's like this. So the first image is showing me a reverse curve of SPI. There is nothing here. I need to completely create a curve of SPI where none exists. So now we need to come back to the first poll question, which is more difficult. Creating an anterior guidance, that too a shallow one where none exists, or increasing the anterior guidance and making it more steeper. And both cases are the complete extreme ends of the smile rehab spectrum. This is one extreme and this is the other extreme, and everything in between falls as a smile design. So you either have this or you have this as smile rehabs. And between the two, this is easier. This is tougher. A shallow anterior guidance is always tougher. It's always tougher because you need to compromise on your functional occlusion. You need to compromise on your anterior guidance, or the angulation that you can give the patient. You need to compromise on the overjet and the overbite that you can give the patient, all for the sake of phonetics. It's just for the sake of phonetics, because otherwise the patient can enunciate and cannot speak properly. So there is no point. So for the sake of the phonetics, you make all those compromises in the functional occlusion, knowing fully well that this is going to cost you a headache of a lifetime in your practice, where your restorations are concerned, and you could probably be dealing with chippages and breakages and fractures and dislodgements. But what I want to highlight is sometimes we don't have a choice. And this is one of those cases. You don't have a choice. You cannot give the patient a steep anterior guidance like in this case, even though I would love to do it, because the patient's phonetics do not allow it. And when we have a case like this in our practice, you really need to sit down and have a very important explaining session with the patient in layman's words. I do not expect I do not expect any one of us to sit down and explain shallow and steep anterior guidance to the patient. But the speed breaker example can be taken to explain to the patient. They do understand that. So the patient can be told that in your particular case, the speed breaker bump that you need to travel with your lower anteriors is very less. Even though I would like to give you a higher bump, I can't, because it's interfering with your speech. So we can't have everything, and sometimes we need to compromise. And there could be, a little bit of issues with the crowds. They may dislodge in the future, and if that happens, you just come back and I re-cement it or rebond it back for you. Okay, so this is something you need to not only tell the patient, because patient management is very important in such cases. Everything is not hunky-dory in our practice. There's many a slip between the cup and the lip. The other thing is informed consent. It's always wiser to take the consent of the patient in writing, when you come to such things, that all post-op instructions have been given in detail to the patient, and you give them one copy and we keep a copy and we ask them to sign it. That helps a lot, because patients have very fickle memories. They are very happy in the beginning and they thank you for all your hard work, and then down the line they tend to forget all your post-op instructions and they don't follow half your instructions, and then that's when the blame game starts. So that is the difference here. So there, when you have a case like this versus a case like this, I'm not saying that this case was very easy. No, it wasn't. It was difficult, but not as difficult as this case. And post-op, there were no issues, because when you have a patient with steep anterior guidance, it just continues. There's never any problem with the restorative work that we've done. But here, it's a whole different ball game altogether, so to speak. Because it's realistic dentistry. And that was one of my aims with this clinical webinar series. I wanted to discuss realistic chairside dentistry and not idealistic dentistry, because idealistic dentistry is not something that we can apply everywhere and in all cases, and certainly not with all patients. So now this was the BISP trial that we gave my patient. Now you can see over here that I have attempted to give a 2 mm overjet and overbite, because that's the ideal overjet and overbite. Now, that brings us to the next question. Why do all prostho textbooks harp on, the 2 mm of overjet and overbite? I mean, what's so great about it? Why do all these textbooks only mention 2? Why can't it be 2.5? Why can't it be 1.5? Why can't it be 1? The reason is because anything more than 2.2 mm becomes too much. It becomes too much. That again causes a different set of issues with a lot of strain in the orofacial musculature. Anything less than 2 mm becomes too less. So what I mean by this is a 2 mm overjet and overbite gives you the ideal steep anterior guidance. And when you have overjet and overbite less than 2 mm, you end up giving the patient a shallow anterior guidance. So naturally, I wanted to give the patient a steep anterior guidance because I did not want problems with my resto later on. And you can see that we have attempted to give 2 mm anterior overjet and overbite over here, but it came at the cost of the aesthetics, because you can see over here that the crowns appear very broad and very boxy. Okay. And my first concern is always the functional occlusion, and it's not the aesthetics, because aesthetics without function has got no value. And as I've said earlier, and I'm saying now too, sometimes you need to compromise. You cannot have everything. But how much you compromise and where you make the compromise is what really determines the success and failure of such cases. So I didn't focus too much on the shape as of now, but I wanted to see what her phonetics was like. And that's where we started having issues, because her phonetics could not go hand in hand with this overjet and overbite. You can see the markings that I've made in pencil over here on the canines. That's because the canines were acting like a lip trap, and she was not comfortable with it. Also, her enunciation was becoming an issue. The fan and the van specifically. The fan and the van did not exactly get interchanged, but it wasn't very clear. The reason for that is because I had increased the cervico-incisal length of the anteriors as compared to her pre-op. Because, see, that's the only way that I can give the patient a 2 mm overjet and overbite. See, this is not a case of an FMR, because what do we do in an FMR? We increase the VD of the patient, right? We crown all the teeth at least in one arch so that we are able to raise the overall bite of the patient, right, from the posteriors to the anteriors. But that's not the case here. She already has an established interocclusal bite in the posteriors. That is the position of maximum intercuspation. I can't fiddle and fidget with that. It is what it is. So the only other way to give a 2 mm overjet and overbite would be to increase the length of the anterior teeth, since I cannot increase the vertical dimension. Now, in some patients that works out, but in some patients it doesn't. And this was one of the patients where it did not work out. And the patient was a case of horizontal growth. So therefore, her pre-existing vertical dimension in the mouth at occlusion was itself very less. And it didn't work out when I increased this. So we had to go back to her pre-op measurements. And, in such cases, you really should have the pre-op casts untouched, where you have not done any preps on them, you have not done anything on them, so that you are able to take a caliper or a divider and measure the cervico-incisal length of the teeth pre-op. And that's exactly what we did. We ended up going back to all the pre-op measurements for all her six anterior teeth. And I had to involve the upper canines here because the canines turned out to be non-vital, but I did not involve the lower canines because they were fine. They were not non-vital or anything. And I didn't actually want to involve these upper canines because I wanted to, in such cases, when you're trying to recreate an anterior guidance out of nowhere, it helps if the canine guidance is intact. It really helps. It helps a lot. So initially, that's the reason why my mock-up did not did not include the canine. I was forced to include the upper canine at a later date, despite my best efforts at trying to preserve the canine guidance. So we went back to her original pre-op cervico-incisal length for her canines, as well as for her anteriors. And you can see that the shape here looks much better than what it looked in the earlier slide. So how did I achieve that? So I call this a game of illusions, because sometimes, we have patients where they have teeth which are broader in the middle and in the incisal third, and there isn't much that you can do about it because you cannot increase the length of those teeth. So it's a game of illusions whereby you round off the mesial and the distal line angles, and the more you round it off, the more you give an illusion of the teeth appearing a little narrow than they actually are. So, there is, I remember that there was a chapter on this, but it was with regards to pontics, which was given in one of our prosthodontic textbooks, a Bible called as Rosenstein. But the same applies to crowns or even composites. The rules remain the same, or the illusions and what you hide where and how you mask it, they remain the same. It's all a play of the line angles at the end of the day. Now, the crowns were zirconia. I mean, there was no question of giving this particular patient Emax. I was just not comfortable with giving the patient Emax or any type of lithium disilicate for that matter. Because as I said, she was a hidden clencher, plus the anterior guidance was more shallow than what I would actually like it to be. So I knew that I was very much envisioning problems with the resto. And I did not want chips and fractures of the lithium disilicate, pure lithium disilicate crowns. But at the same time, they're anterior teeth. I could not give a monolithic zirconia over here. They're highly anesthetic. So I had to give her zirconia, which was layered with lithium disilicate for the aesthetics. And we did not give too much of characterization over here because the patient didn't want it. She didn't want mammalions either, even though they were there in her original teeth. And she said, I really do not want them. And I want more adultish teeth. Those were her words. And so we did not give her too much of texture and too much of characterization so that she appeared more adultish, the way she wanted to appear. And we know that zirconia does not truly bond. and that may be that's true to some extent, but then we do have advancements in newer materials. And when you use adhesive bonds which contain the 10 MDP compound, which is what I used, the bond that I used was Pecorare, and you use a primer on the inner surface of the crowns, a primer which is designated specifically for zirconia. Shofu has one. You do get pretty good bond strengths between the zirconia crown and your abutments. And another thing that I would like to mention over here is that these are all individual crowns. Now, why did I do that? Because again, it would have made so much more sense to give the patient an FPD over here, considering the fact that the abutments have very less height, and therefore retention is going to be an issue with this case. And I'm saying that my anterior guidance is shallow and it's going to cause problems with the rest too. So would it not have made more sense to give an FPD so that they don't keep popping out? Very valid point, but there were two reasons why I did not do that. I knew that my anterior guidance was shallow, and I knew that there was going to be a problem with the rest too. Probably. How much was the issue going to be? I had no idea, because you cannot predict in such cases. Okay, even if you do a couple of these cases, each case would have different issues, and a lot depends on the patient too. So I was not sure what type of issues I may or may not have with the restorative in the future. So if I were to give the patient an FPD and say I had a chip maybe only here, I would have to cut out all 6 just to replace that one tooth. So, and that would be, I'm talking about cutting out zirconia. So no, I didn't want to do that. That was one thing. The other thing was the patient was very particular about her aesthetics. This was something I discussed with the patient too. I discussed the pros and cons. And she was extremely particular about her aesthetics, and she wanted a proper interpapillary fill to take place, and she wanted the crowns to look very, very natural so that they don't look fake at all. And she wanted a proper emergence profile, which sometimes comes only with a very good interpapillary fill when you have individual crowns as opposed to an FPD. So she wasn't prepared for an FPD, because for her, the aesthetics of individual crowns were more important. So these were the 2 reasons why I did what I did. Now this is a cementation of the final crowns. Okay, so when you have a case like this, and I went back to the pre-op incisor-cervical height of all the 6 upper anteriors, you can immediately see that the vertical overjet and overbite is now considerably less than what it was in the bisque trial. So basically, she has now become a case of shallow anterior guidance, and that's very clearly visible in these 2 images over here. There's hardly any overjet and overbite because it was just 1 mm. We could not give her more than that. She's a case of horizontal growth. You can clearly see this. You could see it very clearly in the pre-ops also. The vertical height in occlusion, that is VDO, was less for this case. So there are patients like that. There are patients who have a lower VDO, a lower height in the vertical third of the face, the lower vertical third of the face. And this is where we come back to the, the radical versus the conservative. So now if in such cases you are required to give the patient 6 or even 10 crowns in such an instance, it would not be considered radical, because you're restoring the functional occlusion of the patient, especially when ortho was not an option. But if you were going to crown all the teeth in, say, 1 arch, say the upper arch, just for the sake of increasing this vertical dimension, so that you could increase this proclination possibly and make the anterior guidance more steep, that would be too radical. So this is why we really need to understand that radical and conservative really depends on the case in hand, and what we are seeing then and there at chair side. What is radical for one case may be conservative for another, and vice versa. And the other thing that we need to understand here is compromises have to be made. It is a question of how much you compromise and where. That is what gives you the success or the failure of the case at hand. So now if you see this particular case over here, you can see that we did not achieve a complete interpapillary fill. And sometimes we don't achieve it in cases like this. You are having a case with a shallow anterior guidance. You cannot increase the anterior guidance because the patient has issues with the phonetics. The patient also has a pre-existing hormonal condition. So you're dealing with all of this. So perio was not really an option over here, although we did consider a periodontist right in the beginning itself when I started out the case. The reason was because even if we had done a periodontal intervention and shaved off the hypertrophic gingiva, there was no guarantee that it would not, that we would get the desired interpapillary fill, because the outcome can never be predicted in such cases since the patient has a pre-existing hormonal condition. So considering that we could not predict the outcome, neither of us were very keen to go for any periodontal involvement, neither the periodontist, me, nor the patient. And sometimes, when you correct the functional occlusion, these things sort themselves out somewhere, okay? And you will see how that happens in the later slides. Of course, you cannot guarantee it to the patient. It's something that you need to tell the patient we have to wait and watch. And she was okay with it. She was okay because this was a far cry from what she had when she first came to me, and all her pain and everything was gone. So she was now a really pretty young lady. So this is something I said we need to wait and watch. And at the same time, you need to make sure that there's no food lodgement over here. And we now come to our last compare and contrast. No, I don't think this is the last. I think there's one more after this. Okay, so now we are going to compare and contrast the case today and the case I had in the last webinar for the vertical dimension and the anterior guidance. So you can clearly see that both the cases are cases of low vertical dimension. Okay, now this is where it gets interesting, because traditionally speaking, if a case has low VD, the chances are that they would have a shallow anterior guidance. And you cannot give a steep anterior guidance in a case that has low VD unless you raise the VD. This is the principle on which FMRs are built, okay? But both these cases have low VDO. In fact, this case appears to be far less than even this case. So why is it that there is so much difference in the anterior guidance between both these cases? Here it's actually steep. You can clearly see that this is a case of very steep anterior guidance. This is a case of shallow anterior guidance. It's a barely there. It's almost blink and miss. And here you can see that the overjet is quite a lot, and so is the overbite, because you can see where the incisal edge is, and it's covering at least half of the lower incisors, and here the incisal edge is barely covering the incisal edges of the lower incisors. So again, as I said, these are the complete two extremes that we get in our practice. And the reason why the anterior guidance is so different in both the cases is because of the bite in the anterior region. Here, she was a case of a deep bite in the anteriors. And sometimes with a case of a deep bite, you can get away with a steep anterior guidance. But here the bite was not deep, Here the bite in the anterior region was, it was a normal bite. And therefore the phonetics was interfering, and I could not end up giving the patient a steep anterior guidance over here, even though the overall VD of this case is more than the VD of this case. And what I mean by VD is vertical dimension of occlusion. That's what I mean when I say VD over here. So cases of shallow anterior guidance are far, far, far tougher to restore and handle in our practice as compared to cases of steep anterior guidance. Both are tough. I'm not saying that these cases were any easier. They are not. This case was pretty tough too. But this case takes tough to a whole completely different new level. And this was the value in the arch form of the case at present. So we could not, since I did not involve the lower canines, I could not get a very exact value match with the lower canines, because as I said, you need to compromise somewhere. So, but it was a good match to the upper, and she didn't mind because the lower canines weren't that visible, and she had the option of a little bit of bleaching at a later date if she was interested, but she declined it as of now. This is the eccentric occlusion of this particular case. So we have the position of maximum intercuspation here. We have the eccentric occlusion over here on the right. We have the eccentric occlusion over here on the left. And as you can see, I have given this patient group function over here. And there is load distribution between the upper and the lower anterior teeth over here. why did I give this patient group function? So now the question over here actually is, how did I manage to give this patient group function, especially when I have not involved the posteriors? Now, group function is something that we any which ways give our patient in full mouth rehab. So why did I do it here? Why did I not just give the patient a simple canine guidance? The reason is because the teeth had undergone a lot of bone loss, especially the upper canine. And we have an upper canine which is crowned with a lower canine which is intact. I did not want only the two canines to bear the brunt of all the masticatory stresses, especially in a case like this, where the guidance is already shallow and I'm anticipating issues with the restorations. So that is a major reason why we converted the case from a canine guidance to a group function. Now, canine guidance is actually part of the position of mutually protective occlusion. So we have position of maximum intercuspation, we have mutually protective occlusion, and then we have group function. So mutually protective occlusion is when, as the name suggests, the anteriors protect the posteriors and the posteriors protect the anteriors. So mutually protected occlusion is when the anterior teeth are not in contact in the position of maximum intercuspation, and only the posteriors are in contact. But when they come in an edge-to-edge position, it is the anterior teeth which come in contact, and it's the posterior teeth which disocclude, and therefore they do not contact at that point in time. In short, it is only one which contacts at any given time, either the anteriors or the posteriors. Both do not contact simultaneously. I had an interesting discussion on this with one of the participants in the webinar last time, and she said, I have read, and a lot of authors say that even in the position of maximum intercuspation, there should be light contact between the upper and the lower anterior teeth. But you said that there should not be any contact, and I'm really confused. And I just want to clarify that. Well, nobody is really wrong over here, because when you have a position of maximum intercuspation, like in our previous slide, I'm going to go back to it for just a second. Even if I give an occlusion to the patient where the upper and the lower incisors are not in contact, the canines are. They always are in light contact. So that is one interpretation, okay, because the canines are in contact. And there are certain practitioners who prefer to give a light contact between the upper and the lower anterior, very light contact, almost blink and miss. And I prefer, and then there are others like me who prefer to have no contact over here. Neither of us are wrong. We are both right. And the answer actually lies in Schillingberg, which is one of the Bibles of fixed prosodontics, where he clearly says that up to 25 microns of deviation is acceptable. So you can have up to 25 microns of contact, or you could have 25 microns out of contact, or something in between. And that's absolutely fine. The temporomandibular joint will adjust. The musculature will adjust. There is no issue. So that's something I just wanted to clarify, because there are certain cases where despite
Ma'am, just a small reminder, we're going overtime. 1 hour is already up. So
yeah, we will be going a little overtime, Dr. Urvashi, for this particular webinar, because there were a few extra slides. So the issue is that where was I again? What did I say? Could somebody remind me? What was I speaking on? I lost my train of thought. I'm trying to recollect what I said. Does anybody remember what I was saying?
You were talking about the minimum amount of difference we can have when the temporomandibular joint would adjust.
Yeah. So there are cases where, although I do not want to give contact at all, I prefer to have the upper and the lower anteriors out of contact. There are cases where I cannot do much about it, and they end up being in light contact. That's because the vertical dimension is too less. Sometimes it's a very deep bite. So it does happen in certain cases. So it's okay. Up to 25 microns of deviation either way is okay. It is not an issue. That's one thing I wanted to stress on. So now, how did I convert this case into a group function? It's not easy. Okay, this requires a lot of skill on part of the lab tech too. You need a lab tech who actually understands functional occlusion or is willing to get trained in functional occlusion by you. So if he has a basic understanding of the protrusive movement, and which basically means getting the anterior teeth in an edge-to-edge position and having the posteriors disocclude, group function, canine guidance, a lot of our work becomes easy. So what my tech did over here was he positioned the upper canine a little, slightly in this particular position. Can you see this over here? Okay, he could have tilted it and angled it a bit more on inside. He could have, okay? But the reason he didn't and he kept it in this position was so that he could establish contact between the upper canine and the lower canine, such that the lower canine was slightly palatal. It was only by doing that he could achieve this group function. Had he angulated this canine in the same angulation as the premolar, we could not have achieved this. So again, a little bit of compromise, but it's okay. She didn't look bad. A little bit of compromise sometimes for the sake of functional occlusion, because that makes a whole world of difference over here. This angulation parallel to the premolar versus the angulation we have given at present. The angulation parallel to the premolar would not have given me this group function. It would have just given me a canine guidance, and then it's not worth putting so much of load on these canines, especially when they have lost so much of bone, Group function is much better in such cases by just tilting and giving a different angulation to the canines over here. It's in all cases, but it's something that helped a lot in that particular case. So now this is the last compare and contrast slide. So this is our excursive of the case that we're discussing right now. This is the excursive of my case in the last webinar. So you can clearly see that this is a case of different group functions, okay? What do I mean by different group functions? This is group function in the traditional sense. What we mean in the traditional sense, where we need a minimum 3-point contact and ideally 4. So I have 4 over here. Okay, so minimum 3 or ideally 4. And this is where I have posterior disocclusion. But it's not just the canines which are contacting, it's also the laterals. Okay, so when you have cases like this, they are called as anterior group function. And you find a few cases, it's not something that I've given the patient intentionally. I haven't. She had it. It existed right from before. She had the lateral and the canine touching on the right side, but she had only the canine touching on the left side. So all I did was give her bilateral even contacts. I just did a little bit of enameloplasty over here so that I could get the same load distribution on the left as compared to the right, because I did not want the uneven load distribution to take place, especially in any case where I'm fiddling around with the anterior guidance. I did not want we have the load sharing between canine and lateral, but here we have only between the canines. So sometimes a little bit of enameloplasty goes a long way, so that I got almost equal load distribution over here. But this isn't something that you should go out of your way to give the patient. If it's something that's already pre-existing in the patient's dentition and you cannot change it without doing any radical treatment for the patient, then that's okay. But it's not something that I would go out of my way to give the patient, because laterals are actually not meant to bear the masticatory load and excursion. They aren't. There's a reason why canines are called the cornerstones of the arch, and they play such an important role. They happen to have cusps, and they are a hybrid between the anterior and the posterior teeth. The position in the arch is unique. They're the longest teeth in our arch. They're very strong. And, so therefore the canines are uniquely suited for this particular position, and the laterals aren't. And, you can see here that the disocclusion has been achieved between the anteriors with contact only with the posteriors. So this was the post-operative smile of the patient. And yes, the interpapillary fill over here is something that we really do need to wait and watch, because sometimes we do not have all the answers when we begin. But when you compare her pre-op and post-op, there is a huge world of difference. You can see there is so much of negative space over here in the buccal corridors, and all of the negative space has gotten corrected without touching the premolars, without touching any of the posteriors. All this hypertrophy has gone down. You can see that it's gone down by 99%, and that's a lot. and she any which ways had this this slight lack of interpapillary fill here, and she has a very slight lack here too. But let's see how the case progresses ahead. But all in all, it's absolutely a huge transformation. The shade gradient was given to the patient over here. When we do 6 anteriors, it really helps to go for a gradation in the shade where the value was the least for the centrals, a little higher value for the laterals, and then the value of the canine should match that of the premolar, so that it looks more natural. So when you see from here, the canines are always the darkest in the arch. So either you match the value of the canine to the premolar, or else the value of the canine can be slightly higher, slightly, but not too much. And these things really matter a lot. So now this is the last compare and contrast slide, and you can see the difference in the interpapillary fill over here. This was taken, both the images were taken 1 week post-op, but here I have achieved a beautiful interpapillary small, and this was a case of diastema closure. And although this was not exactly a case of diastema closure, and I still could not achieve the interpapillary fill here, because as I said, cases of shallow anterior guidance are always more tougher than cases of steep anterior guidance. And sometimes the adaptation time that is required for cases like this is a lot more than for cases like this. Because when we talk about functional occlusion, it's not just our teeth alone. We are talking about the entire temporomandibular joint, the disc and the musculature, the entire apparatus in tandem with the teeth, which have to adjust to a new position of functional occlusion. So that adaptation and adjustment can sometimes be faster here as compared to here. And also, this patient did not have any hormonal disorder, and this patient did. So that's something we have to accept. And Dr. Urvashi, I think there is one poll pending, right? This is a slide for the last poll. Dr. Urvashi?
Actually, I already put up the poll results. Sorry?
Have you put up the second poll, please?
Dr. Deepa?
Yeah, have you put up the second poll?
Yeah. I've put up this. Yes, doctor. I put up the second poll, which is better, anterior group function instead of canine guidance, or conventional group function, and more than 50% opted for the first option,
which is
the anterior group function instead of canine guidance.
Okay, so as I said, this webinar is full of surprises. And there are a lot of learnings, perceptions. Our perceptions can sometimes need not always be right. And what we think is right, we don't know what we don't know, to be honest. So, sometimes we think that this is okay or that is okay. But when we start analyzing it in great detail as to why it should or why it shouldn't, we end up sometimes with more questions than where we actually began. And I completely understand that. So, you can feel free to ask any question. No question is too silly. No question is too simple. There is nothing like that. So please feel free to ask. Conventional group function is better than anterior group function. It's not something you should give the patient. If the patient has it pre-existing, then that's okay. We need to fiddle with it. But it's not something I would give the patient on my own. And this was the 3 months post-op of the present case. Okay. Again, even 3 months post-op, I've still not achieved the interpapillary fill over here. So, at this point, I'm thinking, am I going to get it? Am I not going to get it? Sometimes you need to just have the mindset that sometimes you may not get it, and that also happens. Okay, now this is where it gets really, really interesting. This also happens to be the last slide of this presentation. Now, this was 1.5 years post-op. Check this out. So after 1.5 years, finally got that much coveted interpapillary fill between the two central incisors. So you win some and you lose some. Now, there are some losses too in these images, and I'll tell you what those losses are. But this was a very big win for me. Very, very, very big win. So what this tells us something huge, actually. And what that tells us is that if your functional occlusion is correct for that particular patient, which is in harmony with the aesthetics and the phonetics, as well as with the entire temporomandibular joint. Interpapillary fill is something you will achieve on your own. It takes time with certain cases due to certain factors, but eventually you do achieve it. Even if it's a case of shallow anterior guidance, you do achieve it, even though it takes a lot longer, because in most cases it's a month. See, the other case was just a week. But most cases on average is a month, and this was after 1.5 years. But at the same time, you see this over here, and you see this so much inflammation over here. Why are we seeing all of this? The reason is patient compliance. In short, she never turned up. There are a lot of patients who, after getting their smile fixed, feel that they do not need or require the services of the dentist anymore. And she did not come for her oral prophylaxis. She did not follow any of the post-operative instructions. She had stopped wearing her soft splint without discussing with me on her own. And when she finally did turn up one fine day, it was because her crown here had dislodged, And she also, this is the funny part, see, sometimes patients the extent of non-compliance can really surprise us. And even though the patient had been told very clearly that crown dislodgement is something that we are going to encounter in the foreseeable future, because that's just how your bite is. Her crown dislodged, and she didn't come to me for 1.5 months. 1.5 months. I'm not kidding. It's not 1.5 days. It's 1.5 months. And when she finally came to me, obviously the crown was not going to fit on the tooth anymore. There was so much of hypertrophy with these two gingiva, and ideally it would have required a CLP and fabrication of new crowns. But then that's something, again, the patient was not willing to do, because it would mean that, the warranty for these crowns lapses, and they would have to, pay the practice again, which they did not want to do. So they said that, no, let's try. And if it doesn't work out, and, then we'll do what you see. So, oh my God, that appointment was a nightmare. There was so much of Teflon that I had used to retract the gingiva and get the crowns back into position. And, the patient was feeling a lot of pinching in the gingiva around those crowns there for a week or two, which is to be expected, because the overgrowth was quite a lot. But, for all of that I had gone through, and I really feel bad that I didn't document it. This was another mistake that I made. We do make mistakes sometimes. When we think that certain things don't work or are not going to work, we don't bother to document it, because we're like, oh, what's the point? It's anyway not going to work. But sometimes the human body really surprises us, and they actually end up working. And that's when, in hindsight, it's like, oh God, I really should have documented it, because it would have made a great pre-op and post-op. So this was a learning for me too. So considering how she came to me on the day of cementation, and considering a month later after the cementation, I just have a very slight recession over here. Very, very slight. And you can't even see any recession around these crowns. You can't see anything. It's just very slight recession here, and little bit of inflammation here, because she had, as I said, her oral hygiene was an issue, and she had not done the oral prophylaxis, and her hormonal issues were acting up at that point, I guess. But overall, the wins in this case far outweighed the losses. Okay, and I'll be honest. Out of all these crowns, which one did I have an issue with? It was always this one. This was the shortest abutment, if you remember. This was the one crown that would keep popping out, no matter what I did. And as I said, it was because of a bite. But there's one thing that I want to mention over here. See, if a crown dislodges, you can just re-cement or rebond it back. It's a 10-minute job. It isn't much of a headache, provided the patient comes on time to the practice. Okay. And, it isn't so difficult, provided it doesn't chip. Okay, that's where the issue lies. Now, you need to explain this to the patient too. It's okay for a dislodgement, because see, between the two, imagine having a crown which doesn't dislodge but which chips versus a crown which is intact but which dislodges. So the one that has chipped, you need to replace the entire crown, and cutting it out and replacing it again becomes difficult. And the lab will replace it once, but they're not going to replace it multiple times. So if a crown is going to chip, that means there is definitely something that has gone wrong with the functional occlusion. It is not correct. Okay, somewhere there is an issue, and that is the reason it has chipped. But if a crown dislodges, but it is not chipped, then that means the functional occlusion is completely correct for that case. And it is dislodged only because the anterior guidance is shallow and the patient is incising. The patient has a habit of incising, or the patient is incising, or the patient is unable to stop himself or herself from incising because it's just how the bite is. So the latter is always better as compared to the former, because the latter is correctable, the former not so much, because if there is an issue with the functional occlusion, then sometimes if you have to stop that one crown from chipping over and over again, you have to probably redo the entire case. So lot of learnings, in cases like this. And with that, I would like to thank you all for patiently sitting through a very, very tough webinar. I know that the case was really difficult. And, a smile honestly is the shortest distance between two people. But at the same time, the lack of a smile can actually create distance between people. So when you have patients who don't smile even when they want to, okay, because they're so psychologically affected by their smile, or patients who cover their mouth when they smile, so they're never able to, have a smile that reaches their eyes, okay, it actually can cause interpersonal relationship issues, and increase the distance between two people. And you can connect with me on Instagram and Facebook. This is my Instagram handle. This is my Facebook handle. And you can also, sorry, there is an error over here. They should have, my Facebook profile should have been mentioned. My Facebook profile is Dr. Deepa Ravichandran. So in case you want to connect with me, you can connect with me on my profile. This is my Facebook page. This is my Insta page. You can just reach out to me, and I can send you my profile link if anyone needs it. To repeat, my Facebook profile is Dr. Deepa Ravichandran. And were there any other questions, Dr. Urvashi? Is there anything else that I need to discuss?
Yeah, so thank you so much, Dr. Deepa, for that enlightening session. We learned that radical and conservative really depends on the case at hand, and it is chair-side that you have to make a treatment call depending on the individual patient and related factors. So it was truly a compare and contrast session, and we could appreciate the effort that went into long-term treatment planning, keeping in mind smile rehabilitation strategies and not just smile design, keeping function over aesthetics. So, however, we have a few questions which I'm hoping that you can address. One is that could you please elaborate how to increase bonding of zirconia crowns with the abutment?
Yeah. So again, a very good question. Yeah. So we do have newer materials in the market today, as I said. Okay, and see, the reason why lithium disilicate is so preferred is because it bonds very well to enamel. The bond is always better to enamel and not so much to dentine. So when you're in dentine, the bond always gets compromised. But lithium disilicate is preferred for the anteriors because it's more aesthetic. But that said, we need to understand the case on hand, because there are a lot of labs which do not give us a warranty for lithium disilicate crowns, but there is a warranty, for zirconia. And it depends on the bite of the patient. So if I feel that the bite of the patient isn't that great, and there is an issue and something is going to chip somewhere, I always prefer to go for zirconia, because as I said, a chip is not something you can repair that easily, and you can ask for the warranty once, but you cannot ask for it again and again. A debond or a decement is something that I can take care of. I'm not going to charge the patient in such cases, and they know that. They just have to come back to me. It's a little bit of a hassle, a little bit, but that's okay. The alternative is waivers. So now the newer materials that I did mention it in the webinar too. One is the bond with 10 MdP, which is the Curare universal bond, and the other is using a chauffeur primer. So you can ask your lab to sandblast the internal aspect of your zirconia crowns. And but if you do a trial in the mouth, then either you need to use sodium hypochlorite to remove the salivary biofilm, or you need to use a chair-side blaster, or you need to use a product like IoClean in order to clean the internal surface of the crown before you bond it. So that's very important, removing the salivary pellicle. And the other thing is to use the primer. So I have this routine where I always use a primer on the intaglio surface of the crowns, and then I use the 10 MdP bond, the Curare bond on the the shorter abutments. But now GC has come out with a very good material. It's called GC SEM. And GC SEM is specific for teeth which have a lower crown height as compared to the others, where retention is going to be an issue, specifically for zirconia. So GC SEM actually comes with its own primer. So if I use that primer, then I do not need to use my 10 MDP bond. And I have used GC SEM for this case too. It was in that last slide, where I showed the 1.5-year follow-up. When she eventually came, after like 1.5 months after the crowns had been debonded, and it was really, really bad, I had bonded the crowns back using GC SEM. So what I did was, you need to make sure that the tooth is clean of any salivary pellicle. Follow the manufacturer's instructions. Apply the primer on the tooth. I used the Shofu primer on the interior surface of my crown. Of course, after removing any salivary pellicle on the crown and all the residual cement, and then I bonded it back. And GC SEM is a very good material. It's a very good material. But see, you always have a pro and a con. I've met a lot of practitioners who rely a lot on GC SEM because the crowns will never come out. But the problem there is that if there is something wrong with the functional occlusion, the crown will not debond, but it will break. So the very thing that we want can sometimes become a double-edged sword, because when you want it to come out, it will now not come out, especially when you're trying to cut the crown out of the mouth. Almost every one of us will experience this at some point or the other in the practice, where you're sitting with the patient for 2.5 hours in the chair trying to cut the crown out, and it's hugging onto the tooth for dear life. So, so when we use these type of products, we also have to be very, very, very confident of our functional occlusion. So we know that, okay, if anything happens, it's going to debond, but it's not going to chip. Okay, and that's something we tell the patient from before. Okay, that's how your bite is. It may come out, but the point is it's not broken, and it's not broken. It's because your bite is correct, and we cannot do anything beyond this. So sometimes patients understand. If they don't understand initially, they do understand later on. Okay, so consent is again very important. What are the other questions, Dr. Urvashi?
The other question is that what are your techniques to check phonetics?
Okay, so the fan and the ban are very specific words that we use. Okay, so we have fur, ver, sir, sure. So these are the 4 things that we need to check for phonetics. So now fan and van. So when you ask the patient to say fan has to sound like fan. Like when I say fan right now, it's sounding like fan. And when I say van has to sound like van. Now you can clearly see how my lips are contacting the incisal edges of my upper teeth when I say fan versus when I say van. So, there is a difference. So when you say the fur words, the incisal edges of the upper anterior teeth have to come in contact with the inner vermilion border of your lower lip. And when you say van, it's more like a pursing which takes place. It's like van. So you have to judge not just by your auditory, but also by visual. Okay, so that's one thing. The second thing is sir. Sir has to sound like sir, and sure has to sound like sure. So a patient cannot sound like he or she is saying sure when they are saying sir, because that means that there's a lisp over there. Again, the lisp is when the tongue does not have enough space to contact the roof and to contact the palatal surfaces of your upper anterior teeth in the sir sounds, because the sir and the sure, the difference is there is a little bit of air which is let out in those sounds. Okay, and when you don't have enough space for the air to escape, the sir starts to sound like a sure. So sir, it is words like Mississippi, Mayuri. Mayuri is for mer, of course, So, you do ask them to say mer sounds to Emma, Ram, Mayuri, Mississippi. Any words which have a double S in it, Mississippi is specific. It's something we specifically ask them to say, Mississippi, because it sounds almost like a tongue twister, right? Even you can even ask the patient to repeat a tongue twister, okay? And any other sure sounds like shout. Shout is sure, okay? And a sir sound like set, okay? Set, shape, okay? You can ask the patient to say set, shape. That in itself becomes like a tongue twister by itself. So set, shape, really fast. So this is how you check for phonetics. It's visual as well as auditory. And when they are speaking, you should actually check the position of the upper and the lower anterior teeth with respect to the vermilion border of the lips. You can even record it. You can even video record it and then check the video if you're not able to process and check all of this simultaneously. That really helps sometimes. So the next question, Dr. Urvashi.
That's all we have for today. So all the questions have been addressed. So yeah.
Okay. Very, very interesting questions. I really enjoyed the question and answer session more than anything else. Very, very nice questions, whoever has asked them. And thank you for asking such interesting questions.
All right. So at this point, I am just thrilled to announce that we are back again with Dental Reach Digital Conference and Awards DRDCA 22. Dr. Deepa, is the PDF visible on the screen? Can you see it?
No, the PDF is not visible. It's not visible. But before we go to DRDCA, just one small announcement. There is a recording available of this webinar for 7 days. It's for a very short period of time. It's only for 7 days. The reason I'm stressing on this is because a few of you may want to go back and watch this webinar again. Probably certain selected parts because it was pretty tough. So y'all can do that. Y'all can also encourage your friends or anyone else that you think would benefit from this webinar to watch. We will be sharing the replay link with you all, but it's available only for 7 days. So that's something I wanted to say. Back to Dr. Urvashi. No, doctor, PDF is not visible.
I'm not sure why it's not visible. Okay, you have some appreciation.
It will be visible to the audience. It won't be visible.
All right. Dr. Deepa, if you could go through the chat, there's some appreciation for you. In the meantime, I'm thrilled to announce that we are back again with Dental Reach Digital Conference and Awards, DRDCA 22. This year, we have chosen a special class of patients, sports persons, and an ignored problem, sports-related injuries. The solution we are offering is the theme of our conference, Sports Dentistry. So DRDCA 22 Sports Dentistry Edition, Digital International Conference on Sports Dentistry will be held on 12th and 13th of November 2022. It will cover every aspect related to this upcoming subject, from preventive measures to maxillofacial sports injuries to cosmetic and endodontic rehabilitations and much more, and not to forget an entire sports dentistry masterclass. So we invite you to this exciting journey of sports dentistry with us, along with renowned national and international speakers. So for all the future sports dentists listening to us, the brochure and registration details are posted below. Gear up and register fast as only few seats are left. It's an online conference and the recording will be available for 7 days, so no need to worry even if you're tied up over the weekend. Thank you so much. And with the closing of another amazing session, I would like to thank our sponsor, Group Pharmaceuticals, for helping us conduct this webinar. And we will see you all again sooner than later with the next session of our series on programming. Till then, happy